Hi folks, and welcome back. In this video, I want to spend some time talking about harm reduction, in particular harm reduction in the context of the opioid epidemic, which is our topic this week. So I want to begin by talking about what harm reduction is in a really broad sense. Harm reduction strategies are just strategies that aim to reduce the risks of harm associated with certain behaviors or activities. So in a really broad sense, we can think about wearing a helmet while riding a motorcycle or a bicycle as a form of harm reduction, or wearing a seatbelt while riding in a car, or not driving drunk as forms of harm reduction. We can think about it in the medical context in terms of medication that's used to prevent harms from chronic illnesses. So the use of insulin to control type 2 diabetes, or beta blockers and ACE inhibitors to control hypertension. These are kinds of chronic illnesses that can be managed with diet and exercise, that can be managed with lifestyle changes. But when patients struggle to change their lifestyles or choose not to change their lifestyles, we have medications that we can use to help them or help prevent the significant harms that might befall those patients as a result of having these chronic illnesses. So these are harm reduction strategies in healthcare. So the general idea is that if people are unlikely to change their behaviors, then at least we can prevent some of the bad effects on the individual, on the healthcare system, and on society. If people aren't going to change the way they act, we can at least prevent some of the harms that follow from those actions. That's the idea of harm reduction. Harm reduction in opioid use disorder in particular is a pretty broad toolkit. This runs the gamut from things like needle exchange programs, where people with opioid use disorder can bring used needles and exchange them for new clean needles, so they're not reusing syringes, which spreads disease. It includes things like the distribution of fentanyl test kits, so that drug users can know what the drug is that they're using. They can avoid fentanyl and other synthetic opioids if they're heroin users. It includes spreading indigenous knowledge, or recording and spreading indigenous knowledge. Dan Ticcioni talks about Tuda's taste, where an older opioid user that he met explained that he can tell if fentanyl is, or that the heroin that he's using is adulterated with fentanyl by sniffing it or snorting it in a small amount. And campaigns like the one in Baltimore that encourage opioid users, and heroin users in particular, to go slow, to start with a little bit, and then to increase the amount that they're using after they can tell how strong of a high they're going to get from it, or how strong the drug that they're using is. These are kinds of harm reduction strategies. Community naloxone distribution, or layperson naloxone distribution, is a harm reduction strategy. Naloxone, or Narcan, is available as both in an auto-injector and as a nasal spray, and it can stop. It's an opioid antagonist. It can stop an overdose in its tracks. An opioid overdose essentially is a suppression of the automatic nervous system, so that the person who is overdosing slows their breathing and slows their heart rate to a dangerous degree. Narcan stops that process in its tracks. And it's now available in most communities around the country through open prescriptions that are written by providers on behalf of the state governments, or on behalf of state governments. So Virginia has a standing prescription for naloxone or for Narcan. You can walk into any pharmacy and buy it for yourself so that you can have it available, or you can go to a training and spend an hour or two doing a Narcan training and leave with free doses of naloxone that you could administer if you or a loved one or someone in your community or just someone you pass on the street is overdosing from an opioid. You could save a life by carrying Narcan. In Alexandria, where I live, you can do an hour-long training and walk out with Narcan. I carry it. In Fairfax, Fairfax County also does trainings, and you can find information about these on county websites, county health department websites. And it's an important thing to know. Medication-assisted treatments or medication-assisted therapies. MATs are a kind of harm reduction. Medication-assisted therapies come in a variety of flavors. Some of these provide patients, provide drug users with medications that make it impossible for them to get a high from their drugs of choice, or make them feel sick when they take their drugs of choice, and so help them to avoid using those drugs. Other medication-assisted therapies replace the drugs of choice with safer or somewhat safer alternatives that don't give them as strong a high or any high at all, like methadone, which can be used to treat opioid use disorder. Heroin users can go to methadone clinics and get methadone safely, and they're then using a non-illicit or a illicit drug, a legal drug, to get the fix that they need to get right, without getting the high that they would normally get from using heroin. And there are heroin replacement therapies. There are some clinics that will actually, around the world, that will actually provide pure heroin, unadulterated heroin, to addicts, so that they are not out on the street using illicit drugs, so they're not accessing possibly adulterated drugs, so they're not putting themselves at risk of overdose and of arrest in using these drugs. So there's a broad range of medication-assisted treatments. There's also safe or supervised injection sites or facilities, SISs or SIFs. These facilities, which exist across Canada and Europe, are places where drug users can go, bringing their drug of choice with them, and access clean needles and a safe, clean environment to use their drugs, where they don't have to be concerned about being assaulted while they are high, or being robbed while they are high. They don't have to be concerned about overdosing and not being found by anyone, because these sites are supervised by healthcare professionals who can administer naloxone if someone overdoses, and where they don't have to be concerned about contracting some disease from using dirty needles or other dirty paraphernalia. They can access clean equipment there. So they're safe places where people can turn to use drugs that are dangerous to use on the streets, and do it in a supervised location, where they also have access in many of these cases to other medical care. So they have access to treatment for other illnesses that they might be suffering from. They might have access to psychiatric care. They might have access to care for infections that they are suffering. And if they are seeking it out, they have access to drug treatment there as well. So usually these supervised injection sites have counselors on site, or that they can easily refer to when drug users want to get clean, when they are ready to stop using drugs or ready to take a step toward that through medication-assisted treatments or medication-assisted therapies. So these SIFs serve as a kind of gateway to treatment, and perhaps for some users to abstinence. So why are these sorts of treatments so controversial? Why is there such a strong revulsion to harm reduction strategies? Well, I think there are a lot of things going on here. One is that there's a strong stigma against drug use and drug users in the U.S. We tend to moralize drug use. We tend to think of it as a kind of moral failure rather than as a kind of disease or as a kind of habit that anyone could fall into or could develop in certain circumstances. Drug use is often a result of trauma, is often a result of unresolved trauma, a result of the circumstances that one lives in, and should not be stigmatized in the way that it is in the U.S. We shouldn't think of it as a kind of moral failure. We shouldn't think of drug users as moral failures. But in many communities, many people across the country tend to think of it in that way, and so tend to think that drug users aren't deserving of this kind of care. They deserve to be in jail. They deserve to be punished or removed from the community. So I think that's part of where this controversy arises. Another part of it is that this is perceived as wasted resources. The New Yorker ran a really powerful piece a couple of years ago on the opioid epidemic in rural West Virginia, and looked at the reaction of people in the community to the use of Narcan, or the administration of Narcan, to people who were overdosing on opioids. And many people in this community, and in the communities they talked to, said, let them die. They've exposed our kids to seeing them overdose in public. Why should we be paying for paramedics to come out and administer a drug to them? This seems like wasted resources to us. And so I think that's part of the controversy, not understanding that, in fact, it saves money for the community in the end, that it is a more efficient use of medical resources. Because we only see the upfront costs of, say, ensuring that police and first responders have Narcan available to them. Sometimes it's seen as enabling drug use, as being accepting of it, of saying, okay, it's okay, you go ahead and use, and we'll just make sure that you're safe. Or as giving up on people, saying, well, we're just not going to be able to get you to abstinence, so we're just giving up on you. And I think that's just the wrong way to think about harm reduction, right? It's not enabling someone or giving up on them. It's keeping them alive and keeping them healthy until they're ready to make the choice to quit or to seek out some other alternative. There are also moral hazard arguments, that it sort of normalizes drug use, or that the reduced risk that goes along with it, with harm reduction strategies, encourages drug use, because if it's not as dangerous, then more people are going to do it. And there's certainly a concern to be had here. It may be the case that we need to worry about these moral hazards, especially for adolescents. But there's also some research that shows that the knowledge of harm reduction strategies does not, or exposure to harm reduction strategies does not actually encourage more people to use drugs, doesn't make it more likely for people to use drugs. So there's an empirical question here, and the empirical answer is that it just doesn't happen that way. And then there's also NIMBYism, not in my backyard. We see this anytime a a safe injection site has been proposed in the U.S., there's been a strong pushback from the community where it was going to be located, saying, hey, we don't want this here. We don't want drug users coming here to use their drugs. But the thing is, it's often the residents of those communities who would be using those facilities. And it would mean that they're using it in a safe place rather than out on the street. So that there's this sort of NIMBYism. So let's turn now to the ethics of harm reduction and see if some of these ethical arguments can push back against some of the sources of this controversy. I'm going to go through the 4 principles of bioethics: autonomy, nonmaleficence, beneficence, and justice, and make the case from each of these principles. And I'm going to make the case from both the perspective of clinical bioethics and the perspective of public health ethics. So clinical bioethics concerns itself with the treatment of particular patients in a clinical setting. Public health ethics concerns itself with the ethics of public health interventions, the ethics of public health interventions and how they affect the well-being of communities as a whole, not just particular individuals who are seeking out care. So we're gonna be coming at this from both of those perspectives at the same time. So let's start with the ethics of harm reduction and the principle of autonomy. The first thing to say is that addiction is a disease of autonomy, that an addict's brain is affected in such a way, or that a person with substance abuse disorder is affected in such a way that their autonomy is impaired. There is literally a disjunction between the prefrontal cortex, the part of the brain that is responsible for higher order decision making, and the motivation centers of the brain, the midbrain, where the midbrain just takes over. It becomes an automatic process once a craving is triggered to seek out the means to satiate that craving, and that reinforces that automatic process. And the prefrontal cortex is kind of kept out of things, right? It's not part of the decision-making process there. And it's the prefrontal cortex where we might think autonomy is seated, right? It's where the individual has these higher order reasoning capacities that can intervene and say, hey, ho, ho, shouldn't be doing this again, right? So we might think of addiction as a disease of autonomy in that sense. And if that's right, then the question we should ask is, how do we support autonomous decision-making for someone whose capacity to make decisions is impaired? One answer might be to just say they no longer have this capacity for autonomous decision-making at all, and so we ought to be paternalistic and force them into treatment or force them into abstinence, or if they're not willing to do that, then we incarcerate them and prevent them from using these drugs. But I think that's wholly the wrong approach here, because these individuals are not lacking in autonomy entirely. They still can make decisions for themselves. They still can make choices for themselves. Drug users, in many cases, still hold down a job, live lives beyond their drug use, and make good decisions in their lives, in other parts of their lives, and they can make good decisions about their own health. They might still try to eat a healthy diet. They might still try to exercise, yet use these drugs, be addicted to these drugs. And so we shouldn't think of them as not capable of making autonomous choices. We shouldn't think of them as someone who is unconscious or whose capacity for rational thought is wholly impaired or undermined, but rather as someone who in particular contexts has trouble exercising this capacity. And so we need to find ways of supporting them in exercising this capacity to make choices for themselves. So how do we do that? Well, we make sure they stay alive and healthy. We make sure that, and this is somewhat paternalistic, but we make sure that they're not going to kill themselves in making the bad decisions that they make. We support the healthy decisions they want to make, so we make sure that we're in a position to support them when they are making healthy decisions and to help them follow through on those healthy decisions. And we support them until they're ready and willing to quit, or ready and willing to seek out abstinence or seek out some alternative therapy. So we ensure that they'll stay alive and healthy until they reach that point. And harm reduction strategies do that. And we ensure that they are using in a place, in a context where when they make that choice, we can support them in making that choice. And that's what safe injection sites really try to do, or safe injection facilities really try to do. And if the person is never ready and willing, we support them in living as full and healthy a life as possible while they're using. Because they are still autonomous decision makers. They still are autonomous persons. They're still people who live valuable and meaningful lives. And we ought to do what we can to help them live healthy, full lives, even in the context of their drug use. So autonomy certainly, the principle of autonomy certainly says we ought to support them in making good decisions for themselves. We ought to do what we can to support them. And if their decision-making capacities are impaired, we ought to try to support them in making better decisions for themselves. But part of that might be keeping them alive and healthy until they are prepared to make better decisions for themselves. From the public health perspective, the question of autonomy is a little bit different, because the question we have to ask is whether the individual's actions are infringing upon the autonomy or violating the autonomy of others in the community. If they are, then it may be justifiable to truncate their autonomy, to infringe upon their autonomy if they are violating the autonomy of others. And in fact, that's the sort of reasoning that stands behind the criminalization of drug use. If it's a danger to the community because it's linked to violence, it's linked to crime, it's linked to increased medical costs for the community. If it's such a danger to the community, then it's permissible to violate the autonomy of those people who are engaged in this behavior. But maybe that's a step too quick. Maybe what we need to ask is if there's some way of breaking the link between drug use and crime and violence without violating the autonomy of the person using drugs. So if we can prevent them from violating the autonomy or well-being or violating the rights of others in their community without violating their own autonomy, then we succeed at preventing harms to others without violating the autonomy of the drug user themselves, and that would be the best possible outcome. Right? Then everyone's autonomy remains intact. And it turns out that we can, right? We can break the link between drug use and crime and violence by engaging in these sorts of harm reduction strategies. We can break the link between drug use and crime and violence by ensuring that drug users have access to clean, safe places to use these drugs, that they have access to licit drugs, that they have access, rather than illicit drugs, that is, that they have access to medication-assisted therapies, and that they can get their drugs somewhere other than the drug cartels who are responsible for much of this crime and violence. So there are ways of, and legalization or decriminalization also breaks this link between drugs and crime and violence rather explicitly. So there are ways of approaching this problem of the infringement of the rights of others by ensuring that by trying to break this link between drugs and crime and violence without violating the autonomy of individual drug users. So let's turn now to nonmaleficence. Remember that non-maleficence is the do no harm principle, right? Don't commit evil against someone. Here, the case is more complicated from the clinical perspective. Medication-assisted therapies may sometimes inflict harm on people. Some people overdose on methadone, and as medication-assisted therapies became more prevalent or becoming more prevalent in response to the opioid epidemic, more people are overdosing on methadone. But it's still a very small number of people that overdose on methadone. Naloxone can cause precipitous withdrawal and can sometimes cause death. If someone is overdosing and naloxone is administered, or Narcan is administered, Narcan is just the trademark name of naloxone. If Narcan is administered, it can sometimes cause precipitous withdrawal. It can cause patients to feel absolutely terrible. They feel all of the symptoms of withdrawal, the nausea, the headache, the just all of these terrible symptoms. They get really angry about it. And sometimes it can cause such precipitous withdrawal that it is associated with arrhythmias and even heart attacks. And so it can cause harm, but in most cases it saves a life. Right? It doesn't usually just inflict harm, and usually the harm that it inflicts is much less than the harm that it is intended to avoid. So the likelihood of inflicting harm is quite low with the use of these medication-assisted therapies and naloxone and these other harm reduction therapies. And the potential benefits are really quite large. It's keeping people alive and healthy and safe. From the public health perspective, we can ask whether harm reduction inflict harms on the community or cause harms on the community through the normalization of drug use. And there are a couple of things to say here. One is that the normalization of drug use usually precedes public policy, not the other way around. So we're not going to see public policies that push harm reduction until drug use is normalized in the community already. So we shouldn't worry so much about public policy shifts normalizing drug use. The other thing to say, though, is that the effects are just not likely to be even remotely close to the effects that we see, for example, from the glamorization of drug use in pop culture. The fact that there are safe injection sites where people can go to use drugs, or the fact that you're less likely to die from an overdose because people carry naloxone, isn't going to make more people want to use drugs. There's empirical evidence to this effect, which was presented in one of the papers that we read, that it is just not the case that even adolescents who are exposed to safe injection sites see it as a positive thing, or see it as a reason to go out and use drugs, or that it makes them more likely to do so. So I think that this is just an overblown worry. All right, let's turn to beneficence then. Remember, beneficence is do some good. Well, the case from beneficence, I think, is just abundantly clear. Harm reduction strategies do a lot of good. They prevent deaths. They prevent the spread of disease. They reduce antisocial behavior because people are not using as many illicit drugs. People are not engaging in as much crime and violence to access the drugs that they need, and they are using in a place where they can be supported by a community rather than alienated from a community. It reduces crime and violence. It reduces the risk of victimhood because people can use in a safe space where they're not likely to be victimized, to be the victims of sexual assault or other physical assaults, or of robbery. It reduces the risks and nuisance to the community because people are using in safe places where they are not likely to leave drug paraphernalia just laying around on the street where children or adolescents can find them. They're not likely to be a nuisance to the community because they are inside this building, inside this safe space, not using and potentially overdosing out on the street where people will encounter them. And it reduces medical costs. It's a lot cheaper to prevent people from overdosing or prevent people from, getting hepatitis or AIDS or some other disease that is spread through the sharing of needles. It's a lot cheaper to prevent that from happening than to treat them once they have it. Or once they've overdosed. So there's a reduction of medical costs, and that's good for the community. Now, of course, it's not the ideal outcome. The ideal outcome may be abstinence, but we're not going to live in a drug-free society. We've never lived in a drug-free society. No society has ever been completely drug-free. So we should just not focus on that ideal outcome and let the perfect become the enemy of the good, as we sometimes say. We often seek the attainable rather than the ideal in clinical practice and public health. Right? We use insulin to treat type 2 diabetes because we recognize that people aren't going to change their eating habits or exercise habits. We encourage people to wear a helmet when they're riding a motorcycle because we know they're not going to give up this risky activity entirely. Right? We often seek out the attainable outcomes rather than the ideal outcomes, and this is another instance where we ought to do that. And then finally, there's the case to be made from the perspective of justice. Again, the case is really clear. Justice is promoted for individual people who use drugs, for individual drug users, insofar as they can better access social goods such as health care, from which they're often isolated and alienated. Often these people who need health care the most are prevented from accessing that care, and harm reduction strategies make it available to them, and that's an act of justice. Medication-assisted therapy provides opportunities to live a fuller life for individuals who are dependent upon opioids without the risk of incarceration, and it allows people, even when they're not ready for abstinence, to maintain a reasonably good life, to hold down a job, to maintain relationships with their family without the risk of overdose, without the risk of incarceration, without the risk of disease. And harm reduction and decriminalization relieves the burdens of the war on drug on communities of color. Communities of color have suffered the most from the war on drugs, and we continue to incarcerate people of color at high rates and inflict harms on their communities by the criminalization of through the criminalization of drugs. If we accepted harm reduction strategies and even went so far as decriminalization, it would be an act of justice by relieving the burdens on these communities, or some of the burdens on these communities. So we can see from all perspectives now, from the perspectives of autonomy, of non-maleficence, of beneficence, and of justice, harm reduction strategies are ethically justifiable, and the strong reactions against them seem to be rooted in stigma against drug use and against drug users. All right, that's all I've got for this week.